Okay. Okay. Right. So, good morning, everyone. Sorry for the delay. So we are going to carry on with our CME lectures Wednesday and keeping with our topic of non-communicable diseases. So today's presentation is going to be a quite interesting one. Topic itself is quite interesting. Optic disc swelling, hypersonics outsmart the neurologist radar. So it's going to be a bit of a controversial topic, the neurologist radar. So to do this, we have Dr. P.Sriharanathan. Everybody knows him as Sri, right? And he's one of the first retinal surgeons in Sri Lanka. He's one of the first batch of retinal surgeons, and he opted to serve in Kandy rather than staying down in Colombo. So that's a great advantage for us. Thank you very much for coming down to Kandy. And Sri has done his MD in ophthalmology, and he has obtained his fellowship, the pinnacle of his training. And he was trained in UK and in Wales, right? And he is very silent, hardworking person. I know he's very hardworking because I have a personal experience. And also he is very silent and hardworking person, and he has done a lot of research. And then I got to know today in the morning that recent scientific sessions, he has got the best paper and the best video presentation, which is a rare thing to get for Kandy because usually it goes among Colombo people, but it's great to hear that. So without much delay, I would like to call Sri to come and deliver the talk on optic disc swelling, hypersonic outsmart the neurologist radar. Over to you, Sri.
Good morning, everybody. Thank you, Harinder, for that kind introduction. First of all, I would like to thank Kandy Society of Medicine allowing me to have a small lecture with you all in continuous medical education. Thank you very much. Let's dive into our topic. It's optic disc swelling. It's not a new topic. It's an old one. So it was a conditional talk to me. Harinder told, don't talk Sanskrit in this lecture. So the audience are different from your ophthalmology group. So I made it very simple and it's not long also. So hypersonics outsmart neurologist radar. Okay, we'll see what it is. It's a BBC News came in a month ago. China has tested a new nuclear-capable hypersonic missile said to be game changer. Pentagon is call to action because hypersonic weapons travel in the upper atmosphere at more than 5 times of speed of sound, and they can evade conventional radar system. They can evade the European conventional radar system without detection. We'll go. What is a hypersonic missile? It's just for it flies in a lower part of this orbit, that means upper atmosphere, where you can, if you focus it, this radar system detects this missile in upper orbit. That is a common place where this this is a place in the upper part. They simply detect because where this intercontinental missile fly. But these people are developing something in a low orbit where the chance of detection is less. So this is a hypersonic missile. So we'll see how this relates to our topic. Right, I'll consider a small case. This is a 59 years old male. He's a retired teacher, referred by our neurologist for opinion. It's a bilateral optic disc swelling. So if you get a history, he has headache for 10 days with a blurred vision, both eyes, 5 days history, no vomiting, no fever, like neurological features were not there. And past medical history, he didn't have any significant past medical history to put it here. And first he accused of COVID vaccination given 1 month back. So nowadays, it's not surprising people accuse the COVID vaccine. Same way he told you, I vaccinated 1 month ago, right? So this is examination done at neurologist office, and he is not a febrile and pulse and BP. It's not malignant hypertensive. So and neurological examination was completely normal, and no other cranial nerve pulses except something in the optic nerve, second cranial nerve. So ocular examination done, and there's no proptosis or ptosis. They have a doubt of inflamed eyes like that, and pupillary reaction was sluggish. So that is only finding. So this is the usual conventional kind of one tech conventional radar system, which our neurologists or any physician's office have. Is a direct ophthalmoscope. When you look at it through this kind of picture, you get in this patient. You can see obviously there is both discs are swollen, right? So it's a kind of elderly man presenting with bilateral visual loss with bilateral swollen disc. Other neurological findings were negative, and so his neurologist view is going to be it's a papillary nerve. That's the first thing you should exclude, right? That is the basic. So it may be a space occupying lesion, or it may be a intracranial hypertension, or it could be a malignant hypertension. It's a very common condition which is presenting with bilateral optic swelling with headaches, and it masquerades the space occupying lesions, right? And it may be a pseudopapilledema. Other than this papilledema, it may be a pseudopapilledema, like yes, and optic neuritis, one I had, and consecutively other optic disc also can be affected. But at this age, it's little unlikely we are getting a demyelinating type of optic neuritis, but it can happen. And diabetic papillary, and that is also very common. So I have put only the very common condition, not the list of things to go make you all bored. And then with this work, but our neurologist is very smart and clever. He found it is not direct typical papillary nerve. So he thought of sending to ophthalmology side to find out something extra you can find. So he has done everything, basic examination, and because this neurological examination very rarely done in our side, even they don't touch other than the eye, right? So whatever, even checking a BP is it's a nightmare in our unit, obviously, because we have a lot of other works to do. So obviously, a lot of workload and attacks both sides. So he clever neurologist. He sent to us to whether he can find out anything extra. So this is my condition. Then so it's my condition. Is it hypersonic? It was not detected. Is radar. So something. So when you get referral, this is why I think we should think something. What else we can do than what he has done there his point. So hypersonic. Uh, Fortunately, we have some advanced radar technology systems in in ophthalmology unit. Luckily, it's available in our hospital in a free of charge, and they are most of them are non-invasive, not a time-consuming. 5 to 10 minutes, you can do this test. So we are so lucky to have all these things. So one is the slit lamp, which everybody we can't see through a lot of things with the naked eye. It's a biomicroscope. It's a microscope. This will give you an expanded view, not our skill. That machine shows a advanced view. Then other one is a fundus camera. So it will give you a large fundus. It's a 1 millimeter, so it's a 10 millimeter size. Retina will be seen is a large 20-inch screen. So you can pinpoint each and everything, which you don't see in the naked eye. So nowadays we find very difficult to examine the patient because he's wearing a mask and I'm also wearing a mask. He is old and he can't keep the things and the misting all over the microscope. We find very difficult to examine. So if I can't examine this, I do just take a fundus photograph and I look at the screen and I can detect more than what I see on real-time patient examination. So we have other one. This is called optical coherence tomography. It's a very expensive equipment, but it's a very simple. It's located in one small room, so we can take a retinal photograph, cut sections in higher resolutions, like 5 to 7 micrometer, very high resolution. We can't think about it. To give good, nice cut sections within a minute, in a few minutes, we can take it. And, so this kind of advanced radar system we have. So we use this to tackle some of the hypersonics. So what we did is we did some few extra things, but yeah, the major groundwork was done by a neurologist. We have done few extra things. What we have done is this is the one he has done, and I went to something we found in a biomicroscope. There are some inflammatory changes in both eyes. So once there's an inflammatory change, it's my area. I mean, it's our area. We can most of the time it's not going to be a life threatening. Maybe sight threatening, so but not life threatening. So we can happily we found my God, I found a good thing, right? So we check the visual acuity. It was hand movements. He can see only the hand movements in the left eye, but the right eye is better. He can see little far, and the color vision is both sides severely impaired. So in a slit lamp, we can see this kind of pupil. One point is attached here to the lens of the patient's. I think you can. This is the lower lid, this is upper lid. This is a pupil where it is irregular shape. You can, if you look for it, you can find it with the pen torch. If you see this thing, so you can set point. You can refer to us immediately. I mean, something inside the eye, not normal. So in a naked eye with a pen torch, you can detect the posterior. If there is synechiae, that means there's inflammation going on inside the eye. So intraocular inflammation, it's our work to do, right? And that is a point you look for. And how is the fundus camera pictures? This is a fundus camera picture we have. So you have a large area from the disc. How many discs? It's a 4-5 discs from the center of the disc. So you can get a large area coverage, and you can see there this line. There's a place where the edema extends up to this level, and you can see a small hemorrhage, not much of hemorrhage, and you can see some vertical lines here, the folds, because our slit lamp biomicroscope is a two-dimensional view. When you look through this our lamp, you get a three-dimensional. You can appreciate the elevations. You can appreciate the elevation, but the direct ophthalmoscope is a two-dimensional view, which you won't be able to see the stereoscopic view. So that is the advantage of checking in a slit lamp with a variables lenses. So this other eye is a bad eye. You can see the swelling, and we can go how far we can go. We can go very far away from the disc. So these cameras are very, very powerful. You can take so many things. Unfortunately, sometimes we don't use much, but it can be done. So for that, you have to go behind the technician to get it done. Like so, nowadays our trainees are very, very enthusiastic. They go behind and get it done. These things. So now the thing goes. No, it's not a general problem now. This patient, he has bilateral swelling, not from the center. It's coming from maybe something in our area, local area. So one possibility is a posterior uveitis. That is, posterior means any structures behind the iris is called posterior segment. So that area is some inflammation. If you look at the pictures also, they are not crispy enough, not because of our camera is fault. No, it is because of the inflammation, the media become hazy. So that's why you don't get a crispy, sharp images there. So that is one reason. Those things will give us clues, something going on inside. So other possibilities of posterior scleritis, the sclera, posterior part, can get this kind of inflammation due to systemic illness, which can present as bilateral optic disc swelling, and they are very painful. They get pain when they move the eye. So simple history will guide you. And other common thing is a thyroid eye disease. These are the common things which are belong to us, which can present as bilateral optic disc swelling, other than the generalized causes. So this is the optical coherence tomography. This is available in our hospital, and this is a picture you get it. You can get a cut section. It's equal to the anatomical structure of the retina. It gives a good. It's a fovea, and all the 10 layers of the retina can be visualized with the reflective status. It's an infrared camera which gives you a color coded images, or it may be a gray pictures, and it gives you a lot of information about it. It's a choroid you can see, this is the sclera and the photoreceptors, and you can get this is a very clearly. So it's a very advanced technology. With that, we can get a lot of information. So if you go to our patient, it's like this. So this is a normal. This is our patient. You can see the baby things. That is a retinal pigment epithelium is like folded like this, a large area of fluid, and these are the areas, these hyper reflective areas are the areas where you get inflammatory exudates. So inflammation going on in this area behind the choroid and in the vitreous also. So those inflammatory things, subtle things, can be detected with this marvelous machine. So this is a typical picture of particular condition. So basic investigations were done for this patient. ESR was normal, and serum calcium is being done to exclude sarcoidosis, because sarcoidosis also can present. And these things are not uncommon to cause like this thing. And so yeah, plan. First time I think when they came, he already had done a MRI because it's an emergency, and lumbar puncture also done. So these things will give you some ideas of how for our differential diagnosis. So now what? So, so summary is a headache, with a bilateral visual loss with a panuveitis. Panuveitis means all the area, anterior segment to posterior segment, the uvea is inflamed, and it is granulomatous and papillitis. Now the swelling, the reason we found is a papillitis, not inflammation, right? And the OCT, the machine has shown this kind of picture. What it is? It's called Vogt-Koyanagi-Harada disease. So the name is, it's an Arabian plus Japanese involved this. So this disease was described in 18th century. One person, first person, then another person added something else also, like Koyanagi and Harada, and this is a combination of multi-system disease, right? But it is not uncommon, or it's not rare disease in our country. We get the same day we got two patients from one we are referred to us, and other than that we got, so like that, it's not uncommon. So few things about BPH syndrome. It's a multi-system disease, autoimmune. Right? So you get in this age group, and Japanese and Hispanic it was described, but we get a lot of patients. Significant number, and this HLA association also there. So our registers are trying to find whether they have this HLA association for our patients, and these entities are described. The first part is Vogt-Koyanagi disease is a skin changes and anterior uveitis, and Harada has neurological features with an exudative retinal detachment, what you see in our patient, and CSF features, and you can get melanin engulfed macrophages in the CSF analysis. We tried in our patient, but we couldn't find melanocyte engulfed macrophages in our patient. So there are four stages are described, starting from prodromal, that time they get headache and pain, then it went to uveitic, that is uveitis, then become convalescent, and the late stage only the skin features comes out. So like prodromal, they get it's like a viral illness, start like that, and blurring of vision, ocular pain, and neurological speed features are all they will present with these features. So the uveitic features, you can get lots of changes from front to back, and when convalescent period, they become alopecia and poliosis, vitiligo changes are seen in these patients, or sometimes they present with hearing loss also. So, this kind of poliosis. So there's a criteria there people have developed to how to diagnose, because this disease is a disease diagnosis by exclusion. You have to exclude a lot of other ocular conditions before coming to a diagnosis. It's not a straightforward diagnosis. So we need to exclude other masquerading conditions. So it comes to the bottom of the list, but it's common. And it is a disease which responds very well with simple treatment. Does MRI helpful in diagnosis of VKH syndrome? Yes, unless you look for it. So we have to realize with the radiologist for this. We have to talk to them whether look for VKH features, like they can include diffuse choroidal thickening with the sparing of sclera. So it doesn't involve the sclera, but inner part of the sclera is called choroid. It's involved. So that is one of the typical features, and retinal detachment. And this enhancement of both leptomeninges and pachymeningeal enhancements also common. So we need to realize with radiologists, unless otherwise they will look for mainly the soil, because they have to look so many other things unless you guided them. So these are the features we found in our patients, like this choroid involvement without involving the sclera, and you can see that enhanced dura here, but is a leptomeninge is not involved. So those radiological features were found in our patient. Dr. Mary helped us to find this, get this information, because when we revisited the MRI again, we found in our patients also have imaging biomarkers in here. So the treatment will be very simple. It's a steroid. It's a steroid, but you need to give oral steroid for a longer period, 6 months. You need a follow up, and they get good vision. And it's not a blinding if you have started treatment. So simple. You don't need to go for these biological blockers, and unless very resistant. But most of the time, our patients, the steroids work very well, and they are very responsive. So what we have gathered from here is lack of communication between specialists operating different medical fields can be lead a significant diagnostic delay, especially with the rare multisystem disorders, like and crossing the knowledge boundaries, which are often not clearly defined such disorders, is essential to reach the goal of early diagnosis and treatment. Is also referring and getting the opinion from other fields. It will prevent the delay of diagnosis. So my thanks goes to Dr. Mary. She helped us to for this MRI scanning reporting. And Dr. Ranjan Arisinghe, he is our budding registrar, budding surgeon, very enthusiastic people. They work together to get more detail about our patient. So this is our 10th anniversary meeting. I have conducted last week. We got a best surgical video and best posters, and knocked off the Colombo best points. Thank you.
I very well remember this patient actually with visual impairment. I think some other hospitalization and patient has detected in this TDA. So when neurological perspective, when we get a patient with this TDA and severely impaired visual acuity, so the two things crosses our mind at this age, whether it's peritonitis, whether it's inflammatory optic neuritis or other gain differential diagnosis, or we often consider AIOA, anterior ischemic optic neuropathy. So I want to ask now, this is the main two differential that we often come across in medical registers also in this patient. How to differentiate these two, inflammatory optic neuritis from AIOA? Especially the young person comes more likely to be inflammatory optic neuritis, right? Can you give us few advices how to differentiate these two, AIOA from inflammatory optic neuritis?
One thing is from the history, young age, optic devices like the profound color vision loss compared to visual activity. The visual activity is around 6 to 12 minutes. Color vision loss is profound. And they get pain with the eye movements. And two things from the history. And then profound visual activity loss. The visual activity loss is more AIO than optic neuritis. And it changes in optic neuritis, getting better in 1 or 2 weeks, and it evolves. But AIO, they don't get much change in the visual activity. But if you look at the this if AIO looks more aggressive and more hollow, they get more hemorrhages than compared to defining right. But other than that, we can do fundus angiogram. And there is but fundus angiogram, you get that this is leaking most of this AIO, but compared to right, you don't get those will give some clues, and we will find out the risk factors area or which may not be there in optic neuritis. So it's a difficult part to differentiate the clear cut manner. Sometimes it's difficult to find out which one is first. So anyhow, both
That's other thing to ask.
no, I have some other condition called central serous retinopathy, which can come like a optic disc edema, it's similar to optic neuritis. When we misdiagnose as optic neuritis, starts seeking steroid, this central serous retinopathy will get aggravated and very difficult to control others. So our main target to explore the central serous retinopathy, which can be easily detected with OCT on the machine. So that point we shouldn't treat. But for this condition, we are going to do the steroids of one arm at that point. Maybe we can revise our diagnosis later in the late stage.
I say patient is optic edema, not we refer to a eye surgeon. I might not justify. But
Yeah, because I don't think, because maybe 10 minutes we are going to spend, but it's worth, because you can cut off unnecessary MRI scan. You are catching somebody else shot. Yeah, it's something like that. Shot and it's worth by it's an clinical, but we can do this investigation 5 to 10 minutes in the continuous manner in a particular time. Otherwise, I don't mind seeing the decision was. How many notes?
obviously get a better speed.
Yeah, we have advanced weather system.
Any more questions? Yeah. So
I wonder whether now our field and your field overlap sometimes. In that situation, actually, my experience is better pure retinal surgeon more than the general. Yeah, but I probably these are more close together. Because I had the same experience when I was a young boy. It was very good. Not our field overlap more than with the general eye surgeon. There is requirement for this one.
So no more questions. They can't see that there are questions or something. They send questions. No chat. Right. So, in the absence of any questions, I would like to invite Dr. Janapati is to read a certificate of participation and the letter to Sriharanathan. Refreshments have been provided, so you can collect your refreshments. Thank you very much for joining.